Hello, good evening. My name is Sven de Keyser. I am now testing my microphone. If someone could just let me know through the chat function if you can hear me. The session is already recorded, so you can't stop asking me to give permission to record the session, because every time you do that, I get a pop-up. The sessions are now recorded by several people, and the video will be made online after each session. So please stop asking me for permission, because then I have to answer a pop-up every now and then. Okay, the microphone works. I believe everybody can see the screen. Then we can start. So my name is Sven de Keyser. Okay, everything works. I am a neuroradiologist at University Hospital of Ghent, and this is going to be the first of several webinars on brain tumor imaging. We are going to start with a small introduction about brain tumors, and we're going to start with our session. So I'm going to start with a short introduction on brain tumors before we jump right into it. What are brain tumors? Well, they are masses in the brain. They are mainly neoplastic, the result of cells abnormally dividing and proliferating within the brain. And there are two major groups. We have primary brain tumors, and primary brain tumors or tumors that originate from the tissues of the brain itself. They derive from the primary brain cells, like the astrocytes, oligodendrocytes, or from the tissues surrounding the brain, like meningiomas that arise from the meninges. Then we have a second very important and a very large group, and those are the secondary brain tumors. Secondary brain tumors are brain tumors that have spread to the brain from a primary tumor elsewhere in the body, mainly through the arterial circulation. And these small tumor deposits can be found in the brain parenchyma, but they can also spread to the meninges, either the leptomeninges or the dura, and cause leptomeningeal metastasis or dural metastasis. So those are the two major groups of brain tumors we have in the general population. Then we have a second important distinction, and this distinction is very important for us as neuroradiologists that is, where is the tumor located? And that is a question you have to ask yourself each time you are confronted with an intracranial mass. Is the tumor located inside the brain parenchyma? In that case, it's an intraaxial brain tumor. Or is the tumor located outside the brain parenchyma? In that case, we call it an extraaxial brain tumor. And the best example we have and know of an extraaxial brain tumor is meningioma. I will teach you some tips and tricks to distinguish the two later when we discuss meningiomas. But first, let's continue our introduction. Like I said, we have two important groups of tumors. We have metastasis, secondary brain tumors, and we have primary brain tumors. When we look at these pie charts, we see that there is an incredibly huge difference between children and adults when it comes to the distribution of these tumors. Metastases are extremely rare in children. They are like less than 2% of brain tumors in children, and the primary tumor in a child is mostly neuroblastoma. So basically all tumors you see in children, practically all, are primary brain tumors. In adults, it's the other way around. Metastases are the most frequent brain tumor in adults, with percentages of 40 till even 60% of brain tumors. So that explains why, when dealing with a brain tumor, the first thing you have to do is ask yourself, what is the age of the patient? Because the age of the patient will determine your differential diagnosis in a very large extent, more than the radiological appearance of the tumor. And this difference between children and adults is not only true when it comes to metastasis, but also when it comes to primary brain tumors. We will not analyze these pie charts in detail, but just look at them visually. Each kind of tumor is represented in the same color, and we see that the distribution is totally different. For instance, meningiomas are the most frequent primary tumor in adults. However, in children, they are incredibly rare. Another example, gliomas and glioneuronal tumors are the biggest group of primary tumors in children. Okay, it's also a big group in adults. But if we look at the kind of gliomas, then we see a huge difference between these two groups of patients. In children, the most frequent glioma is the so-called pilocytic astrocytoma, while in adult patients, the most frequent one is glioblastoma. So, when confronted with a brain tumor, ask yourself first, how old is the patient? And with the two largest groups, children versus adults, because the kind of tumors you will see will be totally different, and that will determine your differential diagnosis. This also explains why I spread these sessions per age. First, we're going to discuss adult brain tumors, and then in a later session, pediatric brain tumors. So we have metastasis and we have primary brain tumors. But we don't just have one kind of primary brain tumors. You just saw these pie charts. We have a whole bunch of primary brain tumors. And every 7 years or so, the World Health Organization publishes a large voluminous book on the classification of central nervous system tumors. And when I was a young resident, I read it and I wanted to know all these tumors by heart and be able to recognize them on imaging. But it's an impossible task. This is from the latest classification of the World Health Organization. We have over 100 different types of primary brain tumors. If you want to know them all, well, this is complete madness. It's impossible, but luckily you don't have to know them all because a lot of those are very rare and a lot of them are extremely frequent. So if you just know the most frequent ones and you know them well, you will be able to recognize or diagnose most brain tumors, taking into account the age of the patient. So, and this was the British ska pop group Madness, so this was kind of a joke. What kind of primary brain tumors are there? So there are more than 100. To simplify things, we can group them in several tumor families, and there are only 11 of them. So just knowing these, please stop asking to record because then I get this bothersome pop-up and it's a bit annoying. The session is being recorded as we speak and will be put online on YouTube after the session. So we have like 11 groups of tumor families, right? If you know these, we already know a lot. Let's analyze them. What kind of tumor groups are there? This one is the biggest one and the most important one, I believe, the group of the gliomas and glioneuronal tumors. This is a very large group. These are a group of tumors that histopathologically, the neoplastic cells resemble primary glial brain cells, such as astrocytes, oligodendrocytes, ependymocytes, or sometimes they resemble neurons, the glioneuronal tumors. This group can be subdivided in a couple of subgroups, and the distinction is also important, so I'm going to go in a little bit more detail here. First, we have the group of diffuse gliomas, and contrasting with the diffuse gliomas, we have the circumscribed gliomas, or the circumscribed astrocytic tumors. What's the difference? Well, pathologically, diffuse gliomas or gliomas that grow diffusely into the brain parenchyma. And this makes these tumors very tricky because they are very difficult for a neurosurgeon to resect completely. The tumor is very infiltrative, and even if it looks sharply demarcated on imaging, you can be sure that there are microscopic tumor cells located in normal appearing brain. So these tumors are tricky bastards. They have a tendency to recur, and they have also a tendency to undergo malignant transformation. So these are the diffuse gliomas. The circumscribed gliomas, on the other hand, are, as the name implies, very sharply demarcated tumors. These tumors can be resected completely, and if the neurosurgeon manages to resect them completely, surgery is often curative. When it comes to the diffuse gliomas, we have two subtypes. We have adult type gliomas, and those are the ones I'm going to discuss today. And these include glioblastoma, oligodendroglioma, and astrocytoma. And then we have the pediatric type, which we will discuss later on, and which are subdivided in high-grade tumors and low-grade tumors. And this is an example of a glioblastoma. Then circumscribed astrocytic tumors are mainly pediatric tumors. These include pilocytic astrocytoma, the most frequent benign primary brain tumor in children, but also the so-called subependymal giant cell astrocytoma, a tumor seen in children with tuberous sclerosis, and pleomorphic xanthoastrocytoma. What other subgroups are there? We also have the so-called glioneuronal tumors. These are not that frequent. These are generally very benign tumors. These are often associated with epilepsy because they arise often in the cortex. And why is that? These tumors often contain neoplastic neuronal cells. And the best known of these are the ganglioglioma and the DNET, which often tend to occur in the temporal lobe and are often associated with refractory epilepsy. And then we have here another example, a central neurocytoma, which is a very rare intraventricular tumor, but with a very characteristic appearance. And lastly, in the group of the gliomas, we have the so-called ependymomas, which is also a very diverse group. These are tumors that derive from the ependym cells, the cells that line the ventricles. So it is normal to find them in the ventricular system, and your classical posterior fossa ependymoma is located in the fourth ventricle. But this is a bit surprising. There is also something called hemispheric ependymomas, and these occur supratentorially and can be extraventricular. These are rare and difficult to recognize and diagnose. Then we have the subependymoma, which is a very benign tumor, which we frequently see on imaging as an incidental finding in adult patients. We have ependymomas in the spinal cord, and spinal ependymoma is the most frequent intramedullary neoplasm of the spine. And lastly, myxopapillary ependymomas. So this is just a short overview, but this overview is important because it will give you something to hang on to when I discuss all these separate tumors in more detail. Then what other groups are there? Very quickly, we have meningiomas, the most frequent primary extraaxial brain tumor in adults, rare in children, and generally benign in more than 90% of cases. We have tumors of the sellar region, which arise from the pituitary, and the best known and most frequent one is the pituitary adenoma. Another type belonging to this category is the craniopharyngioma, which we will see more frequently in children. We have nerve sheath tumors. These can be schwannomas or neurofibromas. Schwannomas are best known. We can find them in the spine, but also intracranially. And intracranially, the best known and the most frequent location is the cerebellopontine angle, where we find the so-called vestibular schwannoma. Then we have a group of tumors that are more rare and which are frequently or more frequently seen in children. But the diagnosis is not that difficult because some of these tumors have a very characteristic location if you know they exist. What do we have? The choroid plexus tumors, which are primary tumors that originate from the choroid plexus. This is generally a pediatric tumor. The majority of patients are very, very young children, and the tumor arises in places where we have plexus. So typically the trigone of the lateral ventricles or the fourth ventricle. Then we have a group called the pineal tumors. Those are tumors that arise from a specific cell type that is only found in the pineal gland, the so-called pinealocytes. And these can be benign, so-called pineocytomas, or very malignant pineoblastomas. This is a group of tumors that we find in both children and adults. Embryonal tumors, on the other hand, are mainly a pediatric tumor. These are extremely aggressive, highly malignant tumors that derive from undifferentiated cells that are probably embryonal remnant cells that undergo malignant transformation in the pediatric brain. The best known of these tumors is the medulloblastoma, which has a characteristic location in the fourth ventricle, but not only there. So a classical pediatric tumor and the most frequent malignant pediatric tumor. And lastly, we have germ cell tumors. These are rare tumors. They are found in children and maybe young adolescents, but mainly in children, and they are midline tumors. They typically arise either in the cellular region or in the pineal gland, and they can occur at both locations at the same time. So here, the characteristic location and the age of the patient is often a reason to think of a potential germ cell tumor. And then we have a last group of tumors, which are a bit more rare. We have the hematolymphoid tumors, and the best known of this group and the most frequent is the central nervous system lymphoma. Tumors that also belong to this group are the histiocytic tumors like Langerhans cell histiocytosis, Erdheim-Chester disease, Rosai-Dorfman disease. Then we have mesenchymal tumors. Those are tumors that arise from the mesenchyma. So that is basically the cell layer embryologically that gives rise to connective tissue, vascular structures, skeletal tissue, and so on. And examples of these kind of tumors are the solitary fibrous tumor of the dura, a tumor that is extraaxial, and the main differential diagnosis will be with meningioma, and the hemangioblastoma, often associated with von Hippel-Lindau disease. And lastly, we have a very rare group of tumors called the melanocytic tumors. Those are tumors that contain melanin because they arise from melanocytes. Those can be secondary, that is to say, a melanoma can metastasize to the brain self-evidently, but the leptomeninges of the brain also contains some melanocytes, so these tumors can also arise primarily in the brain. But as said, they are very rare, and classically, because they contain melanin, they are hyperintense on T1-weighted images. So these are our primary brain tumors. We started with a list of more than 100 tumors. We narrowed them down, or we grouped them in 11 categories. And now it looks like this is something we can do. We can grasp this. We might not be able to identify every rare tumor, but we might at least be able to put the tumor in a certain category. So the last thing I'm going to say for this introduction, and then we're going to jump right into it, is something about tumor grade, because it is something that will come back a lot. The WHO organization attributes a grade to a brain tumor from 1 to 4, and this grade reflects the malignancy grade of the tumor. So grade 1 tumors are very benign tumors. Grade 2 tumors are low grade, 3 are high grade, and 4 are very high grade. Personally, I avoid calling grade 2 tumors low grade. Why is that? Because we will see that in a lot of cases, these tumors are difficult to treat surgically because they often recur and they often have a potential for malignant transformation. So they are not that innocent, despite the fact that they are only low grade. So I'm a bit careful with throwing around the term low grade. Let's start with adult brain tumors. For this session, we're going to talk about the most frequent intraaxial brain tumors in the adult patient. And what are these? These are, of course, cerebral metastasis, followed by glioblastoma. Then we have astrocytoma, oligodendroglioma, and central nervous system lymphoma. If you know cerebral metastasis and glioblastoma, you already know a lot. Let's start with metastasis. So I already said metastasis, these are the most frequent brain tumor in adults. And I'm pretty sure none of you have a lot of problem diagnosing them or recognizing them, but still I'm going to spend some time on them because we can say a lot more than you might expect. First of all, they are the most frequent one, so always consider them in any brain tumor in an adult patient. But of course, the chance that the tumor is going to be a metastasis is a lot bigger for a 70-year-old than for a 30-year-old. So also think logically. So about 15 to 40% of cancer patients will develop brain metastasis. And 5 primary brain tumors are responsible for about 80% of all cerebral metastasis. And those are lung cancer, breast cancer, melanoma, and then we have renal cell cancer and colorectal carcinoma. This is a typical example of a patient with cerebral metastasis. We see here T1 weighted images with gadolinium, and we see multiple contrast enhancing lesions, either completely enhancing or rim enhancing, scattered around the supratentorial brain, often associated with some perilesional edema. Where do we find metastasis? There are some characteristics that can be found. First of all, the majority are located in the supratentorial brain, about 80% of them. And why is that? Because metastases arise due to arterial spread, mostly to the brain, and the supratentorial brain receives about 80% of the arterial blood supply. 20% are found in the brainstem and cerebellum because these structures only receive 20% of blood supply. Nevertheless, a cerebellar tumor in an adult is most likely a cerebellar metastasis, even if metastases are less frequent in the cerebellum compared to the supratentorial brain. When we look at this image, there's also something that is very characteristic for the location of these tumors. They are all located in the cortex or in the region of the cortical-subcortical transition area. Why is that? Because these are the watershed regions of our big arterial vascular territories. These are the border zones of the anterior cerebral artery, middle cerebral artery, and posterior cerebral artery. In these border zones, the terminal branches of the supplying cortical arteries become narrow, very narrow, causing small tumor emboli to become lodged in the arterioles or the capillaries, and they start growing there and form metastasis. I have actually one time seen this mechanism in action on images. This is a 50-year-old female patient with a thymic carcinoma. We see here a very ugly tumor in the anterior mediastinum. Don't worry, I won't show a lot of thoracic images. We will focus on neuroradiology, but we have to show these images because this patient has something interesting. She also has a thrombus, a tumor thrombus in the vena cava superior. And this thrombus was manipulated during surgery and fragmented, and small emboli metastasized away during the operation. When the patient woke up following thoracic surgery, she had a left hemiplegia. She became an enhanced CT of the brain, and what do we see? We see hypodense areas spread across the supratentorial brain, often with blurring of the gray-white matter junction. What are these? Well, self-evidently, these look like ischemic infarctions with a cardioembolic pattern of spread, which fits the fact that the patient had a dislodged thrombus during surgery, right? The patient received an MRI 4 weeks later, and we see zones of edema in the regions that were also hypodense on CT. There is no diffusion restriction, but keep in mind that this MRI was performed 4 weeks after surgery, so an infarction would no longer be diffusion restrictive. Notice that there is already some cortical tissue loss, So these look like subacute ischemic infarctions, right? Once again, with a cardioembolic pattern. However, something strange happened. 6 weeks later, the patient was admitted at the emergency department with an epileptic seizure. The patient became a new CT, and what do we see? Here we see the infarction we already know about. We see it has become more hypodense, the normal evolution of an infarction on the follow-up CT, but we also see a spontaneously dense nodule right in front of the old infarction. And when we looked at the rest of the brain of this patient, we saw the patient didn't have just one lesion, she had multiple lesions, all dense. These were self-evidently made very suspicious for cerebral metastasis, and the patient received an MRI. When we compare the first MRI the patient got with the new MRI that was performed, we see that the patient developed in the infarcted areas all kinds of enhancing nodules. So these infarctions were actually caused by tumor emboli that grew into full-blown metastasis a couple of weeks later. So this is basically a very exceptional example of the mechanism of hematogenous arterial spread of tumor emboli to the brain. Okay, this was a nice example, but let's go back to the basics because this is an exceptional case. What do metastases look like? A very easy question, it seems. Well, they can look a bit like anything, to be honest. In this patient, we have rim-enhancing multifocal lesions, once again, primarily located at the cortex and cortical-subcortical region. They are hyperintense on T2, but this is ugly fluid. This looks like necrotic debris. This patient has nicely rim-enhancing lesions spread across the brain with a nice central kystic component, or they look nice kystic on the T2-weighted images. This patient has a lesion that is spontaneously T1 hyperintense and has a hemorrhagic fluid level. This was a hemorrhagic metastasis, which can also occur. This patient has a lesion that is spontaneously T1 hyperintense on this unenhanced T1 image, and that was not due to hemorrhage in this patient. So in some cases, metastases can be T1 hyperintense when they are from melanomas. And lastly, we see here a very ugly, primarily solid tumor with a lot of edema. Edema can be very extensive in metastasis, but everything is possible. These metastases barely have any edema. Here we see some, here we see a lot of it. Especially smaller metastases often have little or no edema around them, but everything is possible. So in the end, everything is possible. So we should remember rule number 44 of the Rules of Radiology, an excellent book written by Paul McCubry, which I can advise to anyone. And rule number 44 is, it is never a chordoma. What does it mean? This refers, of course, to a musculoskeletal tumor, but it actually means that when you see something on imaging and it looks strange and bizarre, most likely it's going to be a very frequent, very typical tumor. So a very strange looking bone lesion is probably still going to be a bony metastasis instead of a chordoma. And the same is true for a strange looking intracranial mass in an adult patient. Your first consideration should always be, isn't it just a metastasis? Metastases can be multifocal. They can also be solitary in about 25 to 50% of patients, and they can even be miliary. This is a very nice pattern. I haven't seen many of those in a patient with breast carcinoma, in which the patient has dozens of very small punctate brain lesions, and these were microscopic or very small metastases with a miliary pattern of spread. This is a patient with a lobar intraparenchymal hemorrhage. Yeah, the patient is, let's say, 55 years old. And when we see a patient presenting at the ER with a spontaneous intraparenchymal hemorrhage, the first thing we always have to wonder is why? If there's no trauma, why is this patient having a hemorrhage? Also notice there's a nice blood fluid level in the hemorrhage. One thing you could consider here is it's a lobar hemorrhage, so maybe it's a patient with cerebral amyloid angiopathy. Would be a justified consideration, I believe, especially in an older patient. However, what is a bit exceptional or a bit much is the amount of edema. Take notice when you see a patient with a typical primary hypertensive hemorrhage or a hemorrhage caused by cerebral amyloid angiopathy, they will often be surrounded by edema, but it won't be very extensive. When you see a lot of edema around a hemorrhage, always consider the possibility of an underlying brain tumor. This patient, of course, received an MRI. And what do we see on the MRI? We see once again the hemorrhage with a nice hemorrhagic fluid level visible on T2 and T1 weighted images. And when we perform T1 after gadolinium, we see there's a thick enhancing component surrounding the hematoma. Hematomas, the rim of a hematoma may enhance, but the capsule surrounding a hematoma is generally very thin. This is too much, and this was hemorrhagic metastasis from a breast carcinoma. And this is the same patient with the images a bit more magnified for you. This case is more clear-cut. When it's a solitary lobar hemorrhage, it can be a bit difficult, but when there are multiple hemorrhagic lesions with a lot of edema, well, the first thing you should think about is self-evidently hemorrhagic metastasis. There are several tumors that have a tendency to produce hemorrhagic metastasis. Those are melanoma, renal cell carcinoma, thyroid carcinoma, and choriocarcinoma. But in daily practice, the most frequent tumors will still be breast and lung. Why? Because breast and lung are simply the most frequent primary tumors metastasizing to the brain. So procentually, the number of metastases from breast and lung cancer that are hemorrhagic is pretty small, but because breast and lung are so frequent, hemorrhagic metastases in the brain most likely still originate from either breast or lung cancer. Here we have already seen these images. What is very conspicuous is that this lesion is partially T1 hyperintense on unenhanced T1 weighted images. You could say this is a blood clot because this is a hemorrhagic metastasis. Could be, but when we look at the T2 star images, we see no blooming and the solid component that is T1 hyperintense. This component also appears to enhance. Admittedly, it's not very easy to distinguish contrast enhancement from the spontaneous T1 hyperintense nature, but we see that the lesion becomes bigger and these areas become hyperintenser following gadolinium. This was a melanoma metastasis. Melanomas can contain melanin, not always, but possible. And when melanoma metastases contain melanin, they are hyperintense on T1 weighted images. And that can be useful because when we look at this unenhanced T1 weighted image in a patient with a known melanoma, we immediately see several small cortical and subcortical spontaneously T1 hyperintense lesions. These have to be made suspicious for melanoma metastasis. And these are not hemorrhagic because we don't see anything on the T2 star images. They can be hemorrhagic though, because melanoma has a tendency to produce hemorrhagic metastasis, like in this case. This was the same patient. This lesion is also T1 hyperintense, but associated with blooming on T2 star. The difference, of course, is a bit academic because they are both metastases. Keep in mind, not all metastases from melanomas contain melanin, so they are not all spontaneously T1 hyperintense. A next example, this is something that tends to get overlooked, the pituitary. Metastasis can be found everywhere, truly everywhere. And the pituitary is sometimes, in my experience, a blind spot. We see here an enlarged, very ugly pituitary and pituitary stalk in a patient with breast carcinoma, and also presence of several small parenchymal metastases. This is another patient. So this was a pituitary metastasis. This is another patient. This patient has a melanoma, metastasized, but not to the brain, not yet. We see this on a screening MRI of the brain. Do we call this metastasis? Yes or no? Be careful. Melanomas often get treated with immunomodulatory therapy, for instance, with ipilimumab. That's how it's spelled, ipilimumab. And when you stop treatment with ipilimumab, what do we see? The enlargement of the pituitary disappears and the pituitary becomes normal again. Why is that? Because this was a side effect of the treatment. Immunomodulatory therapies like ipilimumab can cause autoimmune hypophysitis. And when you stop the treatment, the pituitary will once again appear as normal. So when you see an enlarged pituitary in a patient with a known primary, always ask yourself, what is the treatment? Is the patient treated with some kind of immunomodulatory therapy? Consider the possibility of an autoimmune hypophysitis before you call it a metastasis. This is another blind spot in my experience, the pineal gland. He looks perfectly normal and is probably perfectly normal, but on a follow-up MRI in this patient with lung cancer, we see that the pituitary, the pineal gland has enlarged and is now homogeneously enhancing. This was a pineal gland metastasis. What is another location where we can find metastasis and we should always look for? The choroid plexus. It makes sense because the choroid plexus is a very vascular structure and metastasis develop due to arterial dissemination of tumor cells in the brain. So it makes sense that they also end up in extremely vascularized structures like the plexus. And lastly, does anyone see the metastasis in this patient? It's not here. I'm not showing you the unenhanced images, which is a bit tricky of me, but this was also hyperintense on the unenhanced T1 weighted images. This is just a very small subdural hematoma. Where are the metastases, or where is the metastasis? Let's zoom in a little bit. And if you look very carefully, we see that there is contrast enhancement of the surface of the brainstem, and also very subtly between the cerebellar fissures here and the superior vermis. This is leptomeningeal metastasis, spread of tumor cells in the subarachnoid space. Leptomeningeal metastasis, this is another example, often produce a very characteristic imaging appearance, so-called sugar coating. We see here contrast-enhanced coating of the surface of the cerebellar lobules, and it's very nice, despite the fact that it's a dramatic diagnosis, and also here of the brainstem. Also notice that these metastases are hyperintense on these FLAIR images without gadolinium. And this is another example. No, it's probably the same patient. And one thing jumps to the eye, I believe. We see a lot of leptomeningeal enhancement surrounding the cerebellum, but almost nothing along the cerebral convexities. Always, except maybe here in the occipital lobe on the right side. Yeah? But all in all, there is definitely a tendency for leptomeningeal metastasis to develop primarily in the posterior fossa structures. And this probably has to do with the dynamics of cerebrospinal fluid flow. The flow is probably very low in the posterior fossa structures and subarachnoid spaces, causing tumor cells to drop on the surface grow and cause the classical appearance we know of leptomeningeal metastasis. So always carefully examine the cerebellar fissures for possible contrast enhancement in an oncologic patient. And not just the fissures, because you can't look next to it, it's very obvious here, but also the cranial nerves. Sometimes this can be the only thing you see, contrast enhancement along the cranial nerves, because these tumor cells have a tendency to clump along the cranial nerves. And this is another example, just to finish it off. And I've mainly selected it because you see beautiful enhancement of the trigeminal nerve bilaterally, and here of the vestibulocochlear nerve and facial nerve bilaterally, and a patient who clearly has leptomeningeal enhancement in the cerebellar fissures and also a small parenchymal metastasis in the brainstem. So to conclude, the appearance of leptomeningeal metastasis is clear, I believe. These portend a very poor prognosis. About 50% also have cerebral metastasis, and the primaries are the same as for cerebral metastasis. What else can we tell about metastasis? They spread to the parenchyma, to the leptomeninges, but also to the skull and to the dura, and often in combination, especially in prostatic carcinoma. This is a patient with prostatic carcinoma. Prostatic carcinoma rarely metastasizes to the brain parenchyma, rarely metastasizes to the subarachnoid space, but often metastasizes to the bone of the skull in the case of generalized metastasis, skull metastasis, and can grow into the dura and cause dural metastasis, like in this patient. This is another patient. In this patient, it's not caused by skull metastasis because all these dural lesions are located along the falx. You might wonder, how can we be sure this is not meningiomatosis? Now, that's a very difficult one. And I'm going to talk more about it in the next session on meningiomas, because the differential diagnosis purely based on imaging characteristics between dural metastasis and meningiomas can be very, very difficult. These are metastases in a patient with a thyroid cancer carcinoma. These are not extensions from skull metastasis, but have developed due to direct hematogenous spread. And this is the same patient, but just coronal images to better see and visualize the dural lesions. So dural lesions, often the result of skull metastasis. So if you suspect a lesion to be a dural metastasis, inspect a skull. That's the reason we also see them a lot in prostate cancer, and that they are hematogenous. It's sometimes difficult to differentiate them from meningiomas. Okay, that's it for metastasis. Let's go on with the gliomas. So I believe the appearance of metastasis is now clear. When it comes to primary brain tumors in the adult patients, the most frequent one are meningiomas. Then we have a large group of stellar tumors, nerve sheath tumors, some other non-malignant tumors. The majority of primary brain tumors in adult patients are actually benign tumors. In this session, or for the remainder of this session, I will talk about the malignant primary tumors in the adult patient, the most frequent one of which is glioblastoma, followed by other diffuse glial tumors like astrocytoma and oligodendroglioma, and then we have some others like CNS lymphoma. These are the malignant tumors and the topic of this speech. This is another pie chart because I love making them in Excel, and this I just find very handy and very useful to know when you consider intraaxial tumors in adult patients, just those tumors. So we leave out meningiomas, we leave out nerve sheath tumors, we leave out stellar tumors because these have a very typical location. We drop them out and we make a new chart. Then we see that over 75% of intraaxial tumors in adults are either metastasis or glioblastoma. What does this mean? If your resident calls you and says, Dr. De Keyser, I'm looking at a tumor and I have no idea what it is. I just asked my resident, how old is the patient and is it an intraaxial tumor? If he says the patient is 60 and yes, it's an intraaxial tumor in the right frontal lobe, then I just say, without looking at the images, it's probably going to be metastasis or glioblastoma. And you are right, a lot of times, more than 70%, more than 75% of times. If we include other glial tumors like astrocytoma and oligodendroglioma, we even reach a number of 80%. So these are the most frequent ones, and these are the ones we're going to discuss. I'm going to talk a very little bit about the pathology of these tumors because it is important to understand them, because a lot has changed over the last decade or so. Originally, brain tumors were mainly diagnosed by the pathologist based on their histological appearance. For instance, if the tumor cells looked like astrocytes, the tumor was an astrocytoma. If the tumor cells looked like neurons, well, the tumor was a neuronal tumor or a glioneuronal tumor. Like oligodendrocytes, well, then it's an oligodendroglioma, and so on. Nowadays, the histological characteristics of the tumors are not that important anymore. What is important are the molecular characteristics. And this looks a bit daunting at first, very complicated, but it isn't, because you don't have to know all these things. You just have to know the following. When the pathologist looks at a brain tumor and he sees it's a glioma, the first thing he'll do is see if there are mutations in a gene called ADH1. And ADH1 is a gene that has something to do with the Krebs cycle, and mutations in this gene are believed to be pro-oncogenic. Anyway, if there are mutations in this gene, the next thing the pathologist will do is see if there is a co-deletion of the short arm of chromosome 1 and the long arm of chromosome 19. If this is also present, then the tumor is an oligodendroglioma. And it doesn't matter what the tumor looks like histologically, the diagnosis is oligodendroglioma. If the tumor has an HDA mutation, but no 1p19q co-deletion, it's an astrocytoma. What if there is no mutation? Well, then he will check if there is a mutation in a similar gene that is less frequent. And if there is one, we just end up here with either astrocytoma or oligodendroglioma. If not, the pathologist will check some other histological characteristics, some other mutations, and if these are present, the diagnosis will be, in the majority of cases, glioblastoma, so-called HDA wild type, because there is no HDA mutation. If these things are not present, it's something else with something very, very rare, and we won't discuss these groups of tumors. Okay, what else do we need to know? Glioblastoma, HDA wild type, is always WH4, very malignant. Astrocytomas can be low grade, grade 2, or very high grade, grade 4, and oligodendrogliomas are either grade 2 or grade 3. So that's all we need to know about pathology. Let's now jump into our images. Glioblastomas. The diagnosis is often very straightforward. It's often a non-mini diagnosis. We see here a central necrotic tumor located in the corpus callosum anteriorly with an inhomogeneous, thick, irregular, enhancing wall surrounded by edema, containing some hemorrhages and associated with hyperperfusion. We have all the characteristics of a glioblastoma: large, central necrotic, containing hemorrhage, edema, hyperperfusion, right? Also the location. These tumors can, of course, originate everywhere, but they originate mainly in the white matter. And this is something metastasis will very rarely do, originating in the corpus callosum and spreading to both hemispheres. This is something very characteristic for glioblastomas, and when they do that, we call them butterfly glioblastomas. And here is another example of a butterfly glioblastoma in the splenium of the corpus callosum, and notice the presence of central necrosis on the T1 weighted images with gadolinium. Glioblastomas are the most frequent primary adult intraaxial brain tumor, highly aggressive with a very poor prognosis. They are rare in children. High-grade gliomas exist in children, but they belong to different molecular tumor types. Glioblastomas, like we see in adults, are very rare in children. And we usually see them in older adults, starting at age 40 and mainly seen in the older age groups. So keep it in mind. Here, once again, the very typical characteristics of a glioblastoma: a mass with central necrosis, irregular contrast enhancement, hemorrhage in the periphery of the lesion, discontinuous, often the case, with hyperperfusion. And why do we see hyperperfusion? Because of neoangiogenesis. The tumor needs more blood vessels to be able to grow. So the tumor grows its own blood vessels, a process called neoangiogenesis. And this increased microvascular density in the tumor is something we can see on perfusion MRI, because it results in an increased cerebral blood volume or hyperperfusion in the tumor. And on FLAIR images, there is often edema, but beware, this could also be partially non-enhancing tumor infiltrating the surrounding white matter. What do all glioblastomas have in common? For the most part, they always look very, very ugly. So when you see a central necrotic mass in an adult patient, can be surrounded with little edema or a lot of edema, doesn't matter, always consider a glioblastoma. What is the main differential? I show you two patients here. Or these both glioblastomas could be, except only one of them is. Which one is the glioblastoma and which one is a solitary metastasis in a patient with an unknown primary at the moment he receives his MRI of the brain? We can't answer that question, not always, but here we can. And how do we do that? Let's look at these images in a bit more detail, right? T2 weighted images, FLAIR images, T1 weighted images following enhancement. Let's start with patient 1. We see the tumor. The tumor is central necrotic. The tumor has an irregular enhancing wall and is surrounded by non-enhancing T2 hyperintense changes in the surrounding white matter, very likely corresponding to vasogenic edema, right? Also notice that the cortex is not involved. In the second tumor, we also see non-enhancing T2 white matter changes in the surrounding white matter, but we also see that the tumor is also, that the cortex next to the tumor is also hyperintense without contrast enhancement. This is a very characteristic finding of glial tumors. Because of this finding, I am almost certain that this tumor is going to be glioblastoma. What this tumor is going to be, I don't know. It could be metastasis, it could be glioblastoma, could be both. This is based on an article published in 2007 already, and my former department heads and my neuroradiological mentor, Martin Wiesmann of the University Hospital of Aachen in Germany, made me familiar with this article, and it's one of that's the kind of article I like, because it has a very clear-cut message and it solves a problem we deal with in daily radiological practice. These authors compared glioblastomas and metastasis with another and discovered that if there is non-enhancing FLAIR hyperintense infiltration of the cortex next to a tumor, there is a specificity of 91% that it's going to be glioblastoma, but only a sensitivity of 41%. So we have a positive predictive value of 84%, which are good odds. So if you see a solitary enhancing mass in an adult and there is cortical signal increase without enhancement, there is a very high probability that the tumor is going to be a glial tumor, in this case, a glioblastoma. This is another example. I think this is very self-evident with little room for doubt. We see a kystic mass, but with clear cortical infiltration on T2 and FLAIR images without contrast enhancement. The specificity was not 100%, and why is that? Because sometimes it's not easy to see. This is a patient with a large central necrotic mass. Look at the cortex. Is it infiltrated or not? It's difficult to say in this case. I have the impression that I can still see the cortex here, and it's mainly partial volume effect and mass effect of the vasogenic edema, but I am not certain. This was a metastasis from lung cancer. So in some cases, it's not always easy to use this trick, but when you see it, it makes things very easy. Multifocality. Can that be used to distinguish glioblastomas from metastasis? You would say, yes, probably, because metastases are like multifocal in 50 to 75% of cases, right? But glioblastomas can also be multifocal in up to 20% of cases. So don't make the mistake of saying something as a metastasis because the lesion is multifocal. Also notice in this patient that all the contrast-enhancing lesions are located in the same hemisphere and they seem connected by T2 hyperintense white matter changes. This can be due to edema, but could also be a component of non-enhancing tumor infiltrating the white matter tracts and connecting the high-grade components that are contrast-enhancing with another. When we see connecting white matter changes between the enhancing lesions, we call it a multifocal glioblastoma. We don't always see that. This is a patient with 2 tumors, but no connecting white matter changes. Nevertheless, this was glioblastoma. When we see no connection between the tumors, we call it a multicentric glioblastoma. The theory is that there is still a connection, but it's just microscopic and so discrete that we can't detect it on MRI scans, but very likely tumor has spread across the corpus callosum to the other side to cause this second enhancing lesion here. What else can we say about glioblastomas? I told you that metastasis in an adult is the most frequent tumor in the cerebellum, right? And glioblastoma, the second most frequent? No. Glioblastoma is extremely rare in the cerebellum. Why? I don't really know. And this is a patient with multiple irregular central necrotic lesions in the cerebellum, a bizarre spread pattern for metastasis, I would say, but that's the first thing you think about. But when you look at the follow-up scan, and this was only performed 1 or 2 months later, we see that the lesion has now diffusely infiltrated the cerebellum. And this was a very rare cerebellar glioblastoma. So they exist, but they are very rare. And other rare locations are intraventricular glioblastomas, brainstem glioblastomas, or spinal cord glioblastomas. Everything is possible, but these are exceptional locations. What is something else you should look for in a patient with glioblastoma? Look at this. Is this a kyst? No. This was the temporal horn of the lateral ventricle. The tumor contacts the ventricle and there is tumor spread inside the ventricular system, so-called subependymal spread. When you see a glioblastoma contacting the ventricles, always look for contrast enhancement in the ventricular system. We also see it here is the same tumor in the trigone of the right lateral ventricle. Glioblastomas can spread in the ventricular system, and in this case, it's a very large lesion. Yeah, we see complete enhancement and a central kystic mass lesion in the frontal horn of the left lateral ventricle in a patient with clear multifocal glioblastoma. This is another patient with an irregular central necrotic mass that has spread in both cerebral hemispheres. And this patient had sugar coating of the brainstem, here clearly seen in the intrapeduncular cistern. And we also see enhancement here of the anterior wall of the third ventricle. So this is a patient with subependymal spread and leptomeningeal spread. So glioblastomas can also metastasize in the subarachnoid spaces. And in that case, when a primary brain tumor does it, we don't call it leptomeningeal metastasis, but leptomeningeal spread. And this is just a little bit more detail, but it also tells you that when you see a glioblastoma, that's also one of the things you should look for. You should look for other lesions because multifocality and multicentricity are possible. You should look for subependymal spread, especially when the tumor is in contact with the ventricles, and you should look for leptomeningeal spread. This is another patient with a glioblastoma, and this patient had something exceptional. This patient had a very small extra-axial contrast-enhancing lesion at the right temporal lobe. So meningioma is the most frequent extra-axial brain tumor in adults, right? So there is a chance, if you look at the images of 100 patients with glioblastomas, one of them is bound to have an incidental meningioma, right? So we said this is probably a small meningioma, a coincidental finding that has nothing to do with a tumor. But 2 to 3 months later, the lesion had grown, and another 2 to 3 months later had even grown bigger and bigger. And this was a dural metastasis. This is very exceptional and very rare. It's the only case I have seen, but it illustrates that glioblastomas can behave in mysterious ways. There are exceptional cases of glioblastomas metastasizing to the lungs or to the bone, for instance. Then, what is this? This was a relatively young patient. I believe he was like in his 40s, and he presented with epilepsy of the right arm and had he had focal epileptic seizures, and he had a central kystic lesion in the left precentral gyrus. So what did we say? Oh, it's a relatively young patient. The patient has epilepsy. This is going to be ganglioglioma, okay? And the neurosurgeon said, okay, ganglioglioma, that's benign. There's no need to rush things. We're going to perform surgery. We'd like an fMRI, but we could do that a month later because why rush it, okay? And a month later, this tumor has grown to this. This was a glioblastoma. Glioblastomas can be entirely kystic, and I'm showing you this to come back to rule number 44. It's never a chordoma. Always think of the most frequent tumors before you start thinking of the rare things. Glioblastoma is the most frequent tumor. This is an entirely kystic tumor. Okay, not a typical appearance, but it can still be glioblastoma. Then, this is the finishing case for glioblastomas. We see here a patient with diffuse T2 and FLAIR hyperintense infiltration of the deep nuclei and also the bifrontal white matter, but there is no contrast enhancement whatsoever, no areas of central necrosis. What is this? This was glioblastoma, and this is a pattern that used to be called gliomatosis. Gliomatosis is a term that is purely descriptive. We use it when we see something that looks like a glial tumor that diffusely infiltrates white matter, cortex, brain structures, but without enhancement and without areas of necrosis. In the end, you don't know if this is going to be glioblastoma. This is another patient with a gliomatosis pattern, and this patient had an HDA mutant astrocytoma. So you don't know. You can use the term gliomatosis for all eye care, but remember that it's not a pathological diagnosis and that gliomatosis can also be glioblastoma and very, very aggressive and malignant because we often assume that gliomatosis is going to be something low grade. It ain't. So let's see what the time is. Okay, I'm still on time, so I'm happy about that. Let's continue. So we talked about metastasis, we talked about glioblastomas, we have talked about more than 75% of intraaxial brain tumors in adults. We covered a lot. Let's go for 80% now and talk about astrocytomas and oligodendrogliomas. Astrocytomas and oligodendrogliomas belong to the same tumor group. First of all, they are diffuse gliomas. And second of all, they carry a mutation in the HDH1 or HDH2 gene. So the tumors are similar, but not completely the same. They can look very similar on imaging though. Can any one of you tell me which one of these is an astrocytoma and which one of these is an oligodendroglioma? Well, you can't because I muted your microphones. But even if I hadn't, you couldn't because they look exactly the same. This is a WH2 oligodendroglioma. This is an astrocytoma. Nevertheless, the tumors can look very similar, but we can distinguish some characteristics that will help us in certain cases to be more specific. Let's start with oligodendrogliomas. What is specific on imaging for those tumors? Well, first of all, once again, it's an adult tumor, mainly seen in older adults with a peak incidence between 40 and 60, rare in children, and the tumor is mainly found in the supratentorial brain. The tumor is slow growing, but nevertheless, the prognosis is not super, despite its indolent, slow growing nature. And patients mainly present with seizures because the tumor is practically always located in or near the cortex, the brain cortex. This is a patient with an oligodendroglioma, a classical example. The pathologist sees a diffuse glioma. He sees a mutation in the HDH genes, HDH1 or 2. The patient has a 1p19q co-deletion, so oligodendroglioma. Yeah? Could we have suggested this on imaging? Let's analyze our images in a bit more detail. What does an oligodendroglioma look like? Well, I already told you the tumor practically always arises near the cortex at the level of the corticomedullary junction and will infiltrate the cortex. Astrocytomas can do that too, but oligodendrogliomas do it always. Astrocytomas can do it. They are very often a little heterogeneous, a little bit unsharp on T2 weighted images. On FLAIR images, they look almost the same, like on T2 weighted images, which is important for the differentiation with astrocytomas, as we will see. We say that there is no mismatch between FLAIR and T2. And on T1 weighted images with gadolinium, there is no or little contrast enhancement. Okay. What is characteristic for oligodendrogliomas? Calcifications, and a CT can be very helpful in these patients, right? Because we often see them better on CT than on MRI. If we see them on MRI, it's mainly on T2 star weighted images. Calcifications have been described in up to 90% of oligodendrogliomas, but I believe that's an exaggeration, and that's also literature that's outdated because the definition of oligodendroglioma has changed pathologically in the last decade. Nevertheless, if you see a tumor on CT located supratentorially, cortico-subcortical with very coarse calcifications, you can bet almost anything, you should never bet anything, but almost anything that it's going to be an oligodendroglioma. And it was in this patient. There's another patient with an oligodendroglioma. I told you they can be grade 2 or grade 3. In this patient, the tumor is very large, very big, very ugly. There is patchy contrast enhancement. There are coarse calcifications. Based on the calcifications, based on the cortical infiltration, we would already have said it's going to be an oligodendroglioma. And because the tumor is just big and ugly, and that's what I always use when trying to guess if it's high or low grade. Is it big and ugly? Then it's probably high grade. The tumor is big and ugly, so yeah, we're not surprised that this was a WH grade 3 tumor, right? Beware, we used to call these anaplastic oligodendrogliomas, but that's no longer allowed. Yeah, no, they're just called oligodendrogliomas grade 3. Is there a reliable sign? Because I'm just telling you, Van, yeah, if the tumor is big and ugly, it's going to be high grade. That's not very scientific, okay? Is there a scientific way to be 100% sure if the tumor is going to be high grade or low grade? Well, let's just look at two examples. This is patient 1. This was an oligodendroglioma, typical lesion, cortical subcortical, T2 and FLAIR are similar, no enhancement on the T1 weighted images. Also notice that there are no calcifications because you don't have to have them. Like I told you, 90% is probably an exaggeration, certainly for smaller tumors. This is another patient. The tumor looks almost exactly the same, right? Cortical, subcortical, FLAIR, hyperintensity, T2 hyperintense, no contrast enhancement. Is this the same tumor? Almost. They're both oligodendrogliomas, but this was grade 2, this was grade 3. In conclusion, be very, very, very careful. The presence or absence of contrast enhancement is not a reliable feature to grade an oligodendroglioma. You can underestimate them or you can overestimate them. So be very careful if you say something like low-grade glioma, because the chances are you will be wrong. It's better to just call it what it is, most likely an oligodendroglioma, or it could be radiologically an astrocytoma without making any remarks or assumptions about the tumor grade. What is something else that's very typical for oligodendrogliomas? I'm showing you 8, yeah. I have picked them rather arbitrarily out of my collection. And the first thing they all have in common is they are all located supratentorially, and the majority are located in the frontal lobe. Why is a bit unclear, but oligodendrogliomas have a predilection for the frontal lobe. They love the frontal lobe for one reason or another, and that's where we often find them. And then we have one here, frontoparietal lobe, we have one here in the parietal lobe, and one insulotemporal. But the majority, and this is not pure coincidence, most cases I found were located in the frontal lobe, and that's also what the literature says. Another thing about oligodendrogliomas is that they can be hemorrhagic. I haven't seen many cases myself, I must admit. In the medical literature, it is often described that oligodendrogliomas have a propensity to bleed. And I have seen one case recently of a patient who presented with a large lobar intraparenchymal hemorrhage. And I already told you, when you see a lobar hemorrhage, you always have to wonder why. Why does the patient have a hemorrhage? Could it be cerebral amyloid angiopathy? Could always be, but look at the rest of the brain. Not a lot of microvascular changes here, and it looks like a young brain. This patient isn't that old, I guess, so it makes it less likely. The patient received an MRI. We see here the intraparenchymal hemorrhage, right? But something is very strange here. That a subacute hematoma is hyperintense on T1 weighted images, that we know, okay? That shouldn't surprise us. But what is strange is that the hyperintensity is located centrally in the hematoma. Normally, a hematoma becomes T1 hyperintense peripherally, and the T1 hyperintensity spreads to the center of the hematoma. Here we see it the other way around. This is strange. And when we look above the hemorrhage, so this is the hemorrhage, this is a couple of slices above the hemorrhage, we see cortical infiltration. This can't just be edema surrounding the hematoma. Edema never spreads into the cortex. This has to be a tumor infiltrating the cortex, and this was an oligodendroglioma. Okay. So now we have seen a couple of oligodendrogliomas. Let's now look at astrocytomas. They can look similar, but sometimes they don't. Like in, well, not this case, because this is a slide with text. So what can we tell about astrocytomas? They are, once again, adult-type diffuse gliomas, mainly seen in relatively young adults, like 30 and 40-year-olds. contrary to glioblastomas, which start at age 40 and are mainly seen in elder patients, and they can have grade 2 to 4. The terms diffuse astrocytoma, anaplastic astrocytoma, secondary glioblastoma are no longer used. So now these tumors are just called astrocytomas grade 2 to 4. This is an example of an HDH mutant astrocytoma. What do we see? We see a tumor infiltrating cortex and white matter. Cortex is also infiltrated. So as a distinguishing characteristic with oligodendroglioma, it's not always very useful, right? But one thing jumps out. The tumor is not contrast enhancing. That's not helpful either because oligodendrogliomas rarely enhance. But what do we see? We see a difference between the T2 and the FLAIR images. On T2, the tumor is homogeneously hyperintense, right? However, on FLAIR, there is suppression of the signal centrally within the tumor. The periphery is still hyperintense, but the center has become hypointense. This is the so-called T2 FLAIR mismatch sign, and this is very specific for the differentiation of an astrocytoma with an oligodendroglioma. If you see this sign in a glial tumor, you can be, well, 100% sure it's going to be an HDH mutant astrocytoma. When it's absent, however, you can't because the sensitivity is fairly low. How do we explain the presence of a T2 FLAIR mismatch sign? Well, that has to do with the pathological structure of the tumor. When we look at an astrocytoma, pathologically, the tumor often contains a lot of very small cysts, a microkystic background. And it is this kystic nature of the tumor or microkystic nature that causes suppression of the T2 signal on the FLAIR images, giving rise to the T2 FLAIR mismatch sign. And this is another example, and I believe a beautiful example, despite the fact that it is a very ugly tumor. This was a grade 2 HDH mutant astrocytoma, and let's zoom in. We can actually see the small cyst interspersed throughout the tumor. And we see a clear mismatch between the almost homogeneous signal on T2 and the darker signal on the FLAIR images. Let's now compare a classical astrocytoma with an oligodendroglioma. This is a typical mismatch, right? And the tumor is relatively homogeneous and relatively sharply demarcated compared to an oligodendroglioma where there is no mismatch between the FLAIR images and the T2 images, and well, no enhancement, but that's not a useful characteristic anyway. Also notice that oligodendrogliomas are often more heterogeneous and more unsharply demarcated. So what is this tumor? Is this now an astrocytoma or an oligodendroglioma? This is FLAIR, this is T2, this is T1 following contrast administration. We have no mismatch, but I told you there is a low sensitivity of the T2 FLAIR mismatch sign. So if you don't see it, it could be either an oligodendroglioma or an astrocytoma. In this case, it was an astrocytoma. What else can we say about these tumors? Well, this we have already seen, yeah? This tumor looks almost exactly like one of the oligodendrogliomas I've shown you earlier, but was an astrocytoma, which just proves that sometimes it's impossible to differentiate these two tumors from another on radiological grounds. We're almost done. I'm now going to tell you a little bit about predicting tumor grade in astrocytomas on imaging. I told you we have 3 grades in astrocytomas, grade 2, grade 3, and grade 4. And contrary to what we saw in oligodendrogliomas, where it's basically impossible to predict a tumor grade, or chances are bigger with astrocytomas. And to do that, we rely on 3 characteristics: the presence or absence of contrast enhancement, And what does that mean? If we see contrast enhancement, what are we looking at? We're basically looking at deficient blood vessels, a deficient blood-brain barrier. It does not automatically imply that we will find high-grade tumor cells in this region, but there is a higher likelihood, but it's not 100%. What is also pretty reliable, that's perfusion imaging, because in a high-grade tumor, the tumor will often develop neoangiogenesis, and the increased vascular density will be associated with hyperperfusion. Okay, so hyperperfusion or perfusion images can be helpful. And lastly, diffusion-weighted images, because a high-grade tumor will often contain an awful lot of cells that are very tightly, that lay very tightly next to one another. The intercellular spaces are narrow, and there is less possibility for water molecules to diffuse freely, with diffusion restriction as a result. Let's show you some examples. This patient we have already seen, the tumor looks very big, and automatically we might assume that it's going to be high grade just based on its size, but that's a dangerous thing to do. We see no contrast enhancement, we see no diffusion restriction. Contrary, the signal is hyperintense on ADC, which means diffusion is facilitated. Water molecules have more space to diffuse, probably because of the microcystic nature of the tumor. And lastly, we see no hyperperfusion. These are just sulcal blood vessels in the subarachnoid space surrounded by the tumor. All in all, we have the zero characteristics of a high-grade tumor, and this was indeed an HDH mutant astrocytoma grade 2. This tumor infiltrates white matter, basal ganglia, and cortex on the FLAIR images and contains a nodular contrast-enhancing component on T1-weighted images with an gadolinium that also shows some hyperperfusion. I already told you, contrast enhancement does not necessarily equal the presence of high-grade tumor cells. It just points to a deficient blood-brain barrier. However, if the enhancement is nodular, the chances are higher that this is going to be a focus of high-grade tumor. And this was the case in this patient. This was an astrocytoma grade 3. Lastly, diffusion-weighted images. We see a kystic tumor with extensive surrounding FLAIR hyperintense changes with infiltration of the cortex. So this is a glial tumor, no doubt about it. There is patchy contrast enhancement, but not really nodular. So we're a bit uncertain on, is this going to be a sign of a high-grade tumor or not? However, when we look at the diffusion-weighted images, we see that the signal is increased surrounding the kystic component of the tumor with a lower signal in the ADC map. Furthermore, so this is a sign of more cells and a bigger chance of having a high-grade tumor. And furthermore, this region is also shows hyperperfusion on our perfusion images. So all in all, we have signs of a high-grade tumor, and this was a WHO 3 tumor. Last case, this is once again a central necrotic tumor with a solid component that has clear diffusion restriction. It is hyperintense on diffusion, black on the ADC map, irregular contrast enhancement, and hyperperfusion. So all the signs are there. Why is this an HDH mutant astrocytoma and not a glioblastoma? Well, the difference, of course, is pathological, has to do with the presence of an HDH mutation or not. Could we have predicted that this would be an HDH mutant astrocytoma instead of a glioblastoma? Well, the only sign would be the young age of the patient. When you look at the brain, it looks like a young brain. I don't know the age of the patient anymore, but I believe this patient was in his 20s or early 30s, so a very young patient. In the old days, we used to call these tumors secondary glioblastomas, so glioblastomas with an HDH mutation, but this term is no longer used, so don't call them secondary glioblastomas anymore. Okay, finishing case, we see a very small cortical subcortical tumor without enhancement, without hyperperfusion. Should we call it a low-grade glioma? Don't do it. Don't call it low-grade. Call it a glial tumor for all I care, but don't call it low-grade because you can be wrong. And this was a grade 3 tumor. Looks can deceive, so refrain from using the term low-grade. Another example of a tumor with no contrast enhancement whatsoever, but was nevertheless grade 4. So basically the most malignant type of astrocytoma. So the presence or the absence of contrast enhancement does not mean that the tumor is going to be low grade. So this is the last case, really. This was a patient in whom we discovered a subcortical T2 hyperintense non-enhancing tumor, no diffusion restricted, even facilitated diffusion, and no hyperperfusion. So here the term low-grade glioma was coined, and the patient discussed all the possible strategies with the neurosurgeon, and they decided to go for a wait-and-see approach. Let's follow it up, because it's not easy. What do you do with these tumors? Do you follow them up? Do you resect them right away? That's a whole different discussion, and not one we should be having, because it's too complicated. This is a follow-up examination 1 year later, and we see that the tumor has grown. Not much, but visually, you see increase in tumor size, right? Despite the fact that it has only been 1 year. And a year later, the tumor has even grown more. Clearly seen here when we compare the first MRI with the last one 2 years later, especially here. And also this component has extended in size. The tumor has not just grown, something else has changed. Normally, there wasn't any tumor here. Now we see T2 hyperintense changes, so probably tumor infiltration with very, very faint contrast enhancement on the T1 weighted images after gadolinium, and more conspicuous diffusion restriction and hyperperfusion. What has happened here, this was probably a grade 2 glioma that has transformed into a grade 3 or even higher. This was malignant transformation. So as radiologists, I would strongly advise you to avoid low-grade gliomas because it gives the impression that it's a benign tumor, and it's not. Even if it's just a grade 2 tumor, these tumors will grow very slowly, but they will grow, and about 70% of them will become malignant within 5 years. So keep that in mind. These are not innocent tumors. So that concludes our first session, and we are on time, which is not my habit, I must admit. So what are my key messages? So we talked a lot about metastasis and glioblastoma, simply because these are the two most frequent brain tumors in the brain parenchyma in adults, so you must know them. And if you see an interaxial brain tumor in an adult, well, more than 70%, 75% chance it's either one of those two. If you see a solitary necrotic mass, can you differentiate a metastasis from glioblastoma? Sometimes not, unless when you see cortical infiltration, not contrast enhancing, next to the tumor. Then we talked about astrocytoma and oligodendroglioma, which are diffuse gliomas, which often manifest as non-enhancing infiltration of white matter and cortex. They can look exactly the same, but if there is a T2 flare mismatch sign, you can say with almost 100% certainty it's going to be an astrocytoma, not an oligodendroglioma. It is very difficult and impossible to predict tumor grade of oligodendroglioma, so be careful. Astrocytomas, be careful as well, but when you see nodular contrast enhancement, hyperperfusion, and diffusion restriction, you should suggest it is going to be a higher grade tumor anyway. And that concludes our session. Are there any questions? I will go to the chat room for that. And I will also maybe turn off the muting of your microphones, but maybe say in the chat room if you want to ask a question first. Yes, you can now use your microphone, I think. If there are no questions, okay. What about the role of magnetic resonance spectroscopy in distinguishing between glioblastoma and metastasis? Well, I'm going to address that first question. In my personal experience, first of all, I am not an expert in spectroscopy, not at all. In my experience, spectroscopy has a very limited role in the differential diagnosis because in most cases, the diagnosis is not that difficult. Yeah, a lot of patients with brain metastasis already have a known primary tumor, which significantly facilitates the diagnosis for the radiologist, of course. And the main difficulty arises when you have like a solitary mass in a patient with no known primary tumor. In that case, when there is no cortical infiltration, it's very difficult to be 100% certain what is what. It's going to be glioblastoma or metastasis, and you have to differentiate. Spectroscopy will probably show the same in both tumors, right? An increased colon peak, a decreased NAA peak, because that's what spectroscopy shows in the majority of brain pathologies. I do not think spectroscopy is a tool that will allow 100% differentiation, and 100% differentiation will be for the pathologist. Is there literature about MRI perfusion interpretation? Well, of course there is. Ah, Cecilia, wie geht's dir? Ich kann diese Frage auch in Deutsch beantworten, selbstverständlich. Ich glaube, es gibt bestimmt Literatur dazu. Ich habe nichts Persönliches dazu liegen. Ich habe bestimmt etwas liegen, aber ich habe nichts Persönliches geschrieben. Falls du mehr Informationen brauchst, schick mir vielleicht eine E-Mail. Und freue mich, dass du dabei warst, wirklich. Are there any other questions? Oh yeah, for the people who don't speak German, I just told her that I don't have any literature on MRI perfusion, and maybe we should take that up in email. That's a difficult one. There are also studies that actually, it's what is done. That's a question from Tatiana. So the question is it okay to assume that the biopsy site should ideally be chosen based on the location of contrast enhancement? I believe that if that is all there is, you know, you see a tumor that is mainly not enhancing and it has an enhancing component, the chances will still be highest that there you will have high-grade tumors, but sampling error is possible. More reliable in that case would probably be to do a multivoxel spectroscopy and perform the biopsy at the place where the colon peak is highest. But that is not something we frequently do. It's not frequently asked from us either. But I believe in the literature that there is a higher chance that you will have a more accurate location of high-grade tumor if you base yourself on multivoxel spectroscopy instead of merely on the contrast enhancing component. But in practice, it's what is mostly done. Are there any other questions? Okay, I believe not. If people would have any questions or remarks or suggestions, you could all just send me an email. Yeah, I would certainly appreciate a little feedback because it's the first thing we do this for a very diverse audience. And I was very happy to have such an internationally mixed audience here tonight, but things can always be better. So if you have any suggestions, any feedback, any remarks, but if you just want to exchange cases, because I love doing that, if you have difficult cases, you want a second opinion or a second look, always welcome, just send me an email. So if there are no more questions, I'm now going to close the session. And thank you all for attending. Thank you all for your attention and see you in 2 weeks.